In this day and age, depression runs rampant among the masses. Man, woman, and child are susceptible to the effects of depression. For many, life must be put on hold to deal with the many consequences of this psychological disorder. Whether you're a college student with failing grades or an adult who can't seem to get out of the house to perform daily tasks, depression is a real issue that must be addressed. But with all the variability we see in the effects of the population of this disorder, could a novel method of treatment change the game of therapeutic assistance? So what is depression? Depression can occur from many different factors such as stressful or traumatic events, genetics, or faulty brain function. The primary areas of the brain that are affected include the amygdala, the hippocampus, and the thalamus. Major depressive disorder, or MDD, is a devastating mental disorder affecting roughly 14.8 million people in the U.S. alone, and causes serious health and socioeconomic consequences. Symptoms of depression include feelings of sadness, loss of interest or pleasure in activities, changes in appetite or sleeping patterns, fatigue, feelings of worthlessness or guilt, difficulty concentrating or making decisions, and suicidal thoughts. With the prevalence of this issue and its universal effects, many treatments are currently being employed. Psychotherapy or cognitive behavioral therapy, antidepressant medication, and electroconvulsive therapy may all be used to treat depression. Another method, called transcranial magnetic stimulation, is a non-invasive form of brain stimulation that induces an electric current at cortical tissue. So if these treatments already exist, why do we need a new one? Cognitive behavioral therapy and antidepressants both take weeks to months to take effect, if at all, and both ECT and TMS are expensive and they do not produce lasting results. Also, the real concern lies in patients with major depressive disorder. 1/3 of all patients with MDD experience treatment-resistant depression. These patients do not respond to antidepressants for unknown reasons. Some studies predict that health factors play a role in TRD, such as chronic pain, eating or sleeping disorders, and thyroid disease. Treatment-resistant depression is shown to affect women and seniors more than any other demographic. No matter the cause, 1 in 3 people experience the frustration of being unable to treat their depression. This must be fixed. Within the slew of SSRIs, MAOIs, and other acronyms, one novel treatment stands out: ketamine. From our research, off-label use of ketamine as a treatment for major depressive disorder with a robust antidepressant effect can be achieved within 4 hours post-application compared to traditional SSRIs that usually take 2 to 4 weeks before any benefits can be felt. With antidepressants, it can take several weeks to reach a reduction in symptoms. ECT can cause generalized seizures via electrical stimulation of the brain. Plus, antidepressants require steady-state blood plasma levels to work, and we can see treatment-resistant depression in those patients. This is particularly important in cases of patients with the risk of suicidal behavior. Ketamine is well known as a Schedule III party drug and anesthetic, but what is its history? Ketamine was developed as an anesthetic by Park Davis consultant and organic chemist Calvin Stevens in 1962. In 1964, human trials began. In these studies, researchers found that ketamine could rapidly produce profound analgesia with this unique state of altered consciousness and a limited duration effect that could be safely prolonged with repeated administration. They also reported minimal side effects and a lack of severe delirium compared to similar analogs such as phenylcyclidine or PCP. In 1966, the first clinical study of ketamine as a human anesthetic was published. In 1970, a drug known as Ketalar became the first preparation of ketamine approved by the Food and Drug Administration for human use. In 1985, the WHO listed ketamine as an essential medicine. At lower doses, stimulant effects predominate, and users experience mild dissociation with hallucinations and distortion of time and space. Higher doses induce more severe schizophrenia-like symptoms and perceptions that are completely separate from reality. Because of this abuse, and probably the war of drugs, ketamine was placed among the Class 3 substances of the U.S. Controlled Substances Act in 1999. In 2006, the first placebo-controlled study of ketamine in treatment-resistant patients with major depressive disorder began. Through this history, we see that ketamine has a history of medically approved use and some FDA approval, so context is important. There are 3 types of ketamine: S-ketamine, R-ketamine, and RS-ketamine. All of these chemicals have anesthetic properties, but they are different in how receptors in the brain process each isomer. S-ketamine is an FDA-approved anesthetic that is well known and characterized. The S-ketamine enantiomer has a high affinity for NMDA receptor antagonism and has been approved by the FDA for depression. The last type is R-ketamine, which has a less potent NMDA receptor antagonistic effects. This is currently in trials for antidepressant use and will be our focus. In a Yale University study, researchers found ketamine leads to a sharp uptick in the amount of BDNF, which is a protein involved in shaping synapses during brain development and throughout one's lifespan. Depression patients are often associated with lower abnormal amounts of this protein. Ketamine causes a sharp uptick in the amount of BDNF that is released from the neurons. This uptick is required for the increase in dendritic spines that form synaptic connections with other neurons. These two pictures show how ketamine strengthens connections between brain cells. Compared with the control, a rat neuron, in red, treated with ketamine grew more dendritic spines than one not treated with ketamine. This is shown with the yellow arrows. In a newer study by Penn Medicine, researchers found that ketamine-induced activity switches key brain regions tied to depression. To investigate the neuronal mechanisms contributing to the brain, calcium imaging was used to record the activity of excitatory pyramidal neurons in the neocortex of mice before and during ketamine treatment. They found that ketamine weakened several sets of inhibitory cortical neurons that normally suppress other neurons. This allows the normally quiet neurons to become active. The study showed that this dropout in inhibition was necessary for the activity switch in excitatory neurons, the neurons which form the communication highways, and the same neurons that are the main target of commonly prescribed antidepressant medications. A 14-year-long quadruple-blind study published by the NIMH also shows ketamine having a positive impact on depression. This study had people aged 18 to 65 diagnosed with major depressive disorder take a ketamine injection or a placebo for the first time, and then the opposite on the second time, to see how it impacts their depressive disorder. A post-study questionnaire given to participants found a decrease in depression symptoms even in the healthy volunteers. This shows that there are some antidepressant effects involved in ketamine treatment, as it elevated the effects for every participant, even if they were unaware that they received the ketamine injection. Finally, a meta-analysis of studies conducted worldwide from 2009 to 2019 found that ketamine injections do impact treatment-resistant depression in those with major depressive disorder. This meta-analysis shows a significant decrease in depression scores from a ketamine injection versus a placebo effect. The analysis also shows that the effects mostly occur within the first 24-hour time point, and they decrease as time goes on over a 7-day period. The analysis also looked into the importance of ketamine maintenance treatments in helping to alleviate these depressive symptoms long-term. Awesome! So what does ketamine treatment look like? Soluble in both water and lipids, ketamine can be safely administered through multiple routes: intravenous, IV, intramuscular, IM, oral, nasal, rectal, subcutaneous, and epidural. IV administration is 100% bioavailable. IM ketamine is also commonly used and only has a slightly lower bioavailability of 93%. Ketamine can also be administered intranasally, although it has a lower bioavailability of approximately 45% and can vary depending on the amount absorbed through nasal mucosa and the amount that is swallowed. S-ketamine, the FDA-approved isomer mentioned earlier, is available in a nasal spray. Due to ketamine's extensive first-pass metabolism, rectal and oral formulations have limited bioavailability with relatively high concentrations of the active but less potent metabolite norketamine. Due to ketamine's high lipid solubility and relatively limited protein binding, it is rapidly uptaken by the brain and redistributed, with a distribution half-life of only 10 to 15 minutes. Once in the body, ketamine undergoes liver metabolism to several metabolites. Inactive ketamine conjugates and metabolites are renally excreted, and the elimination half-life is 2 to 3 hours. There has been surging interest in the use of ketamine as a potential therapeutic agent for affective disorders, potentially depression. A single dose of ketamine may cause rapid antidepressant effects in otherwise treatment-resistant cases of bipolar and major depression. Remarkably, this also includes the acute reduction of suicidal ideation. Recent neuroimaging studies support the potential anti-anhedonic and antidepressant effects, demonstrating its ability to alter glucose metabolism in regions implicated in mood disorders. Repeated ketamine doses may improve depressive symptoms comparable to, and perhaps even more rapidly than, electroconvulsive therapy, and may even be successful in treating ECT-resistant depression. What's more is that the patent for R-ketamine expired in 2002, meaning that it's incredibly simple and potentially inexpensive to produce as a treatment for depression. All of this sounds more than promising. But for the skeptics out there, you might ask, what are the side effects? Ketamine has multiple dose-dependent side effects, though most are self-resolving. These effects include hypersalivation, hyperreflexia, involuntary muscle contractions. They also include vestibular-type symptoms including dizziness, nausea, and vomiting. At both subanesthetic and anesthetic doses, ketamine is predominantly a sympathomimetic, producing increased arterial pressures and a heart rate through direct stimulation of the central nervous system structures. At higher doses, ketamine also acts as direct myocardial depressant. Cardiopulmonary toxicity is possible but rare, with effects limited to tachycardia, hypertension, and palpitations. One study described ketamine at such doses producing 4 main psychological effects: feelings of intoxication, perceptual alterations in visual, auditory, and somatosensory domains associated with symptoms of depersonalization or derealization, referential ideas and delusions, often of misinterpretation and thought disorder, and negative symptoms such as speech impairment are possible. Given ketamine's wide therapeutic range, death by overdose is rare and usually involves other intoxicants or in the setting of trauma. What may the long-term effects look like? Unlike many opioids and other anesthetics, ketamine does not cause clinically significant respiratory depression in patients. In fact, low-dose ketamine may actually stimulate respiration via bronchodilation. Ketamine is also unique in its ability to preserve upper airway reflexes during anesthesia, which is why patients are able to maintain consciousness. Because ketamine increases cerebral metabolism, it can potentially increase intracranial pressure and has to be used cautiously in patients with space-occupying cerebral lesions in the brain and brain injury. This also means that in some cases, ketamine's cerebral effects may be neuroprotective and potentially beneficial for brain trauma patients. In some clinical settings, it's been seen that ketamine can actually inhibit the spread of cortical depolarizations after traumatic brain injury, which is an effect that may reduce the extension of blood flow damage to healthier tissue in the brain. More recently, cystitis and various urinary tract pathologies have also been reported in long-term ketamine users. Ketamine abuse is also associated with gastrointestinal symptoms, though these adverse effects may be reversible with abstinence. Impaired brain function is possible, although this has only been observed in studies of recreational and self-medicated ketamine users, where the doses tend to be higher than in potentially therapeutic doses. They include the lowering of gray and white matter in the brain due to its neurotoxic effect, higher structural and functional connectivity of dopamine binding, atrophy, or impaired function of the hippocampal, prefrontal, and temporoparietal cortex, due to psychotic and dissociative disorders, which may lead to potential abuse. In summary, ketamine is viewed as a drug that is legal in some countries but illegal in others. In the United States, S-ketamine is legal and FDA approved for depression treatment, but R-ketamine is not approved for the FDA and is currently in use as a research chemical. Ketamine is well characterized as a party drug used worldwide. It has been known to produce a dissociative state that users call a K-hole, an intense psychological experience that has the potential to cause a number of adverse effects. The most well-known use for ketamine is in veterinary anesthesia, where this drug is used for surgery on small animals as well as horses. Ketamine is also used in the rodent cocktail, which is used to anesthetize rats for a variety of purposes in research settings. Although still scheduled as a Class 3 substance, there's been a multitude of studies over the past 15 years working to classify ketamine as a treatment for major depressive disorder. Numerous studies show that ketamine can work as a fast-acting antidepressant, alleviating symptoms in a matter of hours or days. In a typical ketamine treatment, patients sit in a comfortable chair, listen to music while ketamine treatment is administered. Many patients say that therapeutic ketamine feels like floating outside one's body, pleasantly leaving your physical self behind. Some people even gained a heightened sensory awareness. Colors seem brighter, the world becomes peaceful, serene, and beautiful. With your help, we can dive into the realm of studying the effects of therapeutic ketamine. Those suffering from depression could potentially suffer no more. As psychiatrist Daniel Brenner said, it's not just an antidepressant, it's also a medication that shuts down the anti-reward circuitry in the brain that gives rise to shame and self-reproach and the desire to hurt yourself. Treatment-resistant depression can become a term of the past. Patients can feel a connection to others and the world at a level they've never experienced before. In order to revolutionize a treatment, we must think about novel methods which have yet to be explored. With therapeutic ketamine treatment, the effects take less time, they last longer, and they may just save your life.